officials, Dr. Klute, you and your team. Morning to the members online, and also a special welcome to our guest. We have new leaders in the house. I believe they're from Cape Tech students. The leaders of tomorrow, welcome to our committee meeting. And I'm sure we've gossiped about you guys I'm looking at you in 10 years' time. You guys will be sitting here and occupying this space here. But members, we are officially opening the meeting, Standing Committee for Health and Wellness, and the time now is 9 o'clock. And I believe today's date is the 1st of October. Thank you. Thank you very much for making the time. But before we officially start the business of the day, I'm going to allow for a moment of silence for different reflections, and the moment starts now. Thank you very much. Members, we know the drill. And Sis Nomonde, just for the record, I know that Member Walters is caught up in traffic. He will be joining us as soon as he can get here as soon as possible. And then I'm going to do the introductions for the record. I'm Memory Boyson, and I'm the chairperson for the Standing Committee for Health and Wellness. And I'm going to make my rounds to the members in the house, and then I'm going to go to the members online, and I'll come back to Dr. Klute, to you and your team. Thank you.
Good morning, Chair and everyone. My name is Rachel Van Vogel, and I'm a member of this committee.
Thank you.
Good morning, Chair. Good morning, everyone. I'm Donita Stevens, and I'm a member of this committee.
Thank you. I'm going to the members online.
Good morning, Chairperson. Wendy Kaiser Philander, member of the committee.
Thank you very much. We're just waiting for the Iron Lady. She's walked in. Member Van Minen, you're right on time, just for the record.
Thank you very much. I apologize for being late, Chair. But yes, I'm Benedicta Van Minen, and I'm a permanent member of this committee. Thank you.
Thank you, Member Van Minen. Dr. Klute, over to you and your team for introductions.
Thank you, Chairperson. Thank you, members. Keith Klute, the Head of Department for Health and Wellness.
Thank you.
Good morning, Chair. Good morning, members. The name is Anda Ngosi, Chief Director, Strategy.
Thank you.
Good morning, members. Good morning, Chair. Samantha Brinkman, Acting Deputy Director for Information Management and Governance.
Thank you very much. And my favorite lady right at the back.
Good morning, Chair. Susan Smith. I'm the Head of Ministry for Minister Wenger.
Thank you very much. Members, we know that the purpose of the meeting is for us to be updated on the quarterly progress and reports. And that is what we will be getting from the department. And then before I give to Dr. Klute, let me steal your thunder. Dr. Klute, I'm going to start off with some remarks. And members, just for the record and for report back from me as the chair of the committee, last Friday, I had an engagement with the AG's office in terms of the outcomes of the department. And members, just to pat ourselves on the back again, it is good news. As usual, as per the words of the AG, it is our 7th clean audit. And we did go into some details in terms of interrogation of what has been happening in the department. And there are flags, but the flags are not red. And in terms of the engagements as well, there are plenty of opportunity and room to deal with the flag. But I know that the members will ask me what flag. For instance, just as an example, members, one of the things is that the SEM, the procurement issues at some of the hospitals, you know, as I was saying, it is not red, but it's always the matter of when it comes to the quote systems, you know, 3 quotes, and sometimes the 1 quote takes too long and to miss out on deadlines, then we go with the 2 quotes, etc. Those are just the kind of things, you know, but otherwise it is not material issues. And well done, Dr. Klute, to you and your team. And what is also good, and they've really stand on Table Mountain on that, We would all remember, they're normally the COMEFs period, etc. And for the past 5 years, there was no reasons for the AG to report and say, can you guys fix this in the COMEFs, etc., which is also a good thing for where I'm sitting. I'm from a municipal environment, and I know we have sleepless nights, when we expect the COMEFs, and to have that for 5 years in a row and there's no comebacks, it's just thumbs up. I must say thank you very much to the minister, you, Dr. Klute, and the team. It is good news indeed. And Susan, you can convey that as well to the minister. And then also last year, it is something I raised in terms of how can we make this contagious to the other provinces. And I must say that we have started, with the think tanks. The think tank is also a brilliant concept, and I've raised that with the AG, and that is a good step to make this contagious to the other provinces. And Dr. Klute, I've been reliably informed as well. You folks do assist the other provinces at a management level. So thank you very much for that. And then to us as politicians, Member Van Vogel, if we can also reach a stage where, and it's something that we need to have coffee over, where we as the different political parties, probably one way or another, can also have maybe a study group of some sort and engage in terms of at a political level, how can we make this the best health system in the country and not just for the province. And it is definitely something that I'm looking forward to if we can get it at a political level, because at a professional level, Dr. Klute, you guys have started that, and thank you very much. And on that note, Dr. Klute, I'm going to hand over to you for opening remarks. And members, I will give you an opportunity to either on my opening remarks or Dr. Klute's opening remarks in the absence of the minister. Then we can do that. Over to you, Dr. Klute.
Thank you so much, Chairperson, and thank you so much to the members. And my opening remarks, the first comment I would like to make is Minister Wenger is on a well-deserved break and a leave. She's an extremely hardworking political head, and we wish her well on a break. But she did ask me specifically at this gathering just to reiterate a few points. And I would like to do it on her behalf and add my elements to it. And I'm glad you started with the first part, and that we are extremely proud to have achieved 7 clean audits in a row. The maturity of our conversation with the Auditor General is what is reflected by yourself. Because we got to a place where the Auditor General is having a conversation with us. And they're saying, when we find something that can be improved, you own up. You don't try and run away from it or hide it. You are honest. You say, we agree, let's work on it. When you say you're going to improve something and we come back, you've done what you said you're going to do. And in a sense, what the Auditor General is saying to us, because of their track record, that when they raise something, we own it. When we say we're going to do something, they go, look, they see evidence we've done something about it. They actually sitting in a position where the Auditor General is telling us, we can trust you. And because the Auditor General says we can trust you, it opens up an avenue for us to have a different kind of relationship with the Auditor General, which is about honest reflection and continuous improvement and not resting on your laurels. So that's the first comment. The second one, which you rightfully have touched on, is we in the last probably 3 or 4 years, if I have to look at my colleagues in the department and check, we probably have hosted a delegation from every other provincial department in the country at one point or the other. The latest being our colleagues from Gauteng that was here 2 weeks ago and actually came to speak to us about supply chain actually. That's after my interaction with my fellow HODs as part of the national structure. So we have a tech NHC, National Health Council, and the minister serves on the National Health Council with her counterparts. And it was quite, for us, at the level of that engagement, at officials, we work very close together. What also happened is that KZN came with a full delegation, with the premier, the two premiers hosted, the MECs and the cabinets from both cabinets and HODs. And out of that, we've had a deeper relationship with KZN. And when I shared that with the fellow colleagues in the engagement that we have of the other provinces, there is a commitment across us as officials that we are now formalizing that into almost like a think tank arrangement for ourselves as HODs and the national department across the country, because collectively we are stewarding the healthcare system for the country. So I think that's an important second point that you raise as well. And then just to thirdly, to contextualize what we're about to share with you, which is the last quarter of the last financial year in comparison with the first quarter of this financial year. Obviously, that is to bridge over into the session that is coming up, which is where we will have a full day session with yourself or morning session around the annual report, which I can gladly show to you has now been printed and it's ready for that session. And it's really just testimony to the people that is in the room with me today and a lot of other people in the department. We proudly talk to you about our performance. And therefore, our performance is exactly the same conversation we have with you is what we have with the Auditor General. If there are things to improve, we own up. If we say we're going to do something, please keep us to account to follow through so that you, as a standing committee, can in fact also say to you that you trust us in the way we do it. Today, we have here Ms. Nkosi, which is our Chief Director for Strategy, and Samantha is standing in for Leslie Shand. And they're going to share with you the performance thing. And I just want to contextualize this for you. Once a quarter, we bring together probably 100, last time I checked, it was about 180 people, about 180 to 200 people once a quarter to discuss our performance. Samantha is going to give you a slightly elongated version of that today, because that maturity has also got to the place that in that once a quarter, we do deep reflection. We don't just go on the surface, look at whether all the robots are green, all of them are yellow. We're now going under the bonnet. We want to understand what's living underneath. We're asking deeper questions. We're asking, and people are coming to those meetings now so fired up because they want to tell their stories. And the thing that I want to say is when we have quarterly reviews like this, Chairperson, we can look at data and targets and performance. The richness of the conversation is when we start converting those into stories. Now, for today, we're not telling you stories on the data, we're sharing the data. But it would be good if we, at some future point, arrive at the point where we can tell you the story underneath the data. And that's always, Member Windvogel, you've always been, over the years, very clear to us. When we come to data, when we come to this, what is the story of the person on the street? And that's the place where we would all like to go to, is to tell the story, the lived experience of the person getting services from us. So with that, I would like Chairperson, thank you. That's my opening remarks.
Thank you, Dr. Klute. Members, I've just remembered now something that I didn't add, Dr. Klute, that also came out of the meeting with the AG, is that, and it is, I don't know how to feel about this, but it is good news, you know, like in all the samples in the Western Cape, none of the health facilities in the Western Cape had expired stock on the shelves, you know, and they told me, you know, it's not the case in some samples in some provinces, you know, so which gives one the assurance, you know, that what we give to the patients, you know, like it's all ready, it is all within the timelines of the manufacturing dates and expiring dates, which is a good thing. Members, over to you for any comments, engagements regarding the opening briefing by Dr. Klute, Member Van Vogel, and then Member Stevens.
Yeah, thank you, Chairperson. Mine is very short. I must agree with the HOD that I think Department of Health and Wellness is one of those departments that acknowledge where there's what do you call it, for improvement. And really, when you identify those issues, they really try to rectify it. And that's what I respect of the leadership of the department. I so hope that our politicians will employ a similar approach and not play the, what do you call it, the blame game. But I really do appreciate the fact that they are, when there's a problem, they will acknowledge and they will rectify. That's what one thing. So in terms of the clean audits, I think we can always be proud when it comes to the Department of Health and Wellness. As you are saying, there is some few flags. And my view always is that how do we relate our daily lives with clean audits when it comes to the ordinary person out there? How do we change the Karl Bremer Hospital, the experience that patients have there? How do Bella in Robertson, Kailicha, where there's still people sleeping on floors? So how do we, this clean audit, the impact on that? So I want that connection. But I will park there, Chair. But I must compliment the department. Although there's this thing in HOD and Chair, through you, Chair, you can't compliment a fish to swim. So it's supposed to be like that. But the norm these days is we have so many, wat sê ons, goeters wat nie vir ons stel is om te wees nie, that we even applaud a fish to swim. So, but nevertheless, I must applaud them for that. Thank you, Chair.
Member Stevens.
Thank you, Chair. I'm also coming to the clean audits. I just want to know, the department highlights clean audits as an achievement, but do you agree that the clean audit does not necessarily mean that the healthcare system is functioning well? How does the department reconcile celebrating clean audits while patients continue to be turned away at hospitals and clinics due to staff shortages, poor service and lack of assistance? And how was this clean audit communicated to the community? And was there any community or external partner engagements that contributed to this better compliance? And how does the department plan to build on this clean audit to further improve health outcomes and community trust? Because to me personally, I lost trust this week in the department. This coming Saturday, I'm going to bury a young girl, 28 years old, my friend's only child. They just fell, break a leg. No help at the Caledon Hospital. By the time they decided to help her, she was gone. Only 28 years old, a teacher at Verliersdorp Primary School, and my friend's only child. And that doesn't sit well with me. Thank you.
Member Stevens, we're very, very sorry to hear that. And as a committee, our condolences to you and the family. We're very sorry to hear that. Before I give over to Dr. Klute, there's an unknown gentleman in the house. There's an unknown gentleman in the house, and I refuse to continue the meeting unless we know who that gentleman is.
I'm Thomas Walters, a member of the committee. I got stuck a little bit in traffic. Thank you very much.
Thank you, Member Walters. We join at the back as well, next to Susan.
Raphael Friedman, Office of the Minister.
Thank you. And my apologies to the leaders and the doctors and the politicians of tomorrow, the presidents of tomorrow. I didn't give you guys an opportunity to introduce yourself so that we can record you. In 10 years, we're going to play it back to you to say that, can you guys remember that you've been here and now you are taking the lead? So can you guys introduce yourselves one by one? I'll start with the lady right at the beginning and then we'll make our way up. And please press the mic.
Hello, everyone. I am Sibahle Mzana, a second-year journalism student at CPUT.
Welcome. Please press it off. Press yours off. Yeah.
Morning, everyone. I'm Oysen Tlampe, a second year journalism student from the CPUT.
Welcome.
Morning, everyone. My name is Olam Nyande, a second year journalism student at Cape Peninsula University of Technology.
Welcome.
Morning, everyone. And my name is Ronwane Ruboda from CPUT, second year journalism student. Thank you.
Once again, we'll remember you. Thank you. And we'll see you in future. Dr. Clote, over to you and the team. Almost there.
Thank you, Chairperson. So just to start with Member Stevens. So Member Stevens, I have the deepest empathy. So there's a difference between sympathy and empathy. Deepest empathy for the experience when a loved one is lost. Please take our deepest and sincere condolences as a department. As human beings, and that is where we all start when we arrive for work. All of us are human beings. We feel the pain of others when it happens. I can guarantee you in healthcare workers, in the healthcare system, it touches healthcare workers deeply when a patient loses their life. And on behalf of everyone, that's my expression of appreciation to you and thoughts to the family of the young person with a brilliant career ahead of her, whole life a year. And please extend that to the family. And I think that's the point where our conversation with the Auditor General has arrived at. So remember, Windvogel says to commend a fish for swimming is not necessarily what the Auditor General should be busy with. Unfortunately, the Auditor General has been busy with many entities about getting the fish to swim. Our relationship with the Auditor General has got to the point where we are now talking not about the fish must swim. It is actually about the lived experience of the citizen. And in the last 4 audit reports, you will have a section in the audit report. So when we do come to the annual report, we will refer to that section. And it is the Auditor General's first attempt to come to us independently and give me feedback as the accounting officer. And while they find all the processes, procedures, everything is done above board, everything is followed, their first experiences of the experience of the patients, they're giving us independent feedback from their vantage point to us. And it's interesting because actually when they give us feedback and we square up the feedback with the complaints and the things that we get, their experience is because they don't only concentrate on the complaints. They actually, when they go to all the facilities, there's everybody that happens to visit at the facilities. And I must say to you, as an accounting officer, I was actually surprised at the level of them commending us on the experience of patients in our services, more often than not. Because they go to places and they say the facilities are clean. They come into a place, it's orderly. People are generally being communicated to. If somebody has a challenge that needs to be fast-tracked, it generally gets fast-tracked. If somebody has had a negative experience, somebody always follows back through and follow through to come back to the family and all of those. So again, and it's the same principle we say, everything in our healthcare system is not perfect. So the first thing we do is we acknowledge where we can improve. I need to also give you this assurance, though, that this is not just a Western Cape Department of Health issue. You can be anywhere in the world. There's not enough resources to deal with every healthcare need. And one of the hardest things for our frontline healthcare workers is to help them to say, and remember, Windvogel, you will recall a couple of years ago as well, there's quite a few instances where the healthcare system has to tell the family or a loved one, we cannot do any more. And one of the difficult things that we go through is to go through that conversation and walking a journey with the family for somebody passing away. Because what we can offer, or so let me put it, the potential of what we can offer to save that person's life has reached a certain point. And even at that point, our dignity must even be felt more and our empathy more than when we try to do and keep the person alive. So I can give you assurance, Member Stevens, from where I'm sitting, and the Auditor General is starting to have the conversation with us. What's the lived experience of patients? And again, those pockets, it's quite interestingly when we do have the opportunity to discuss it, that, you know, they go through all the places. And I'm going to say, okay, now where did you find this? And they say, no, we were there, we were in Easter River. This is what we found in Easter River. This is what we find in Kailicha. This is where we find in the places. So it's not also a select sample of places where we all know things are going well, and where it includes places where there are pressures on the system. So I really just want to extend that to Member Stevens. And Member Van Vogel, you're right. We must go beyond and accept that our job is to swim. We mustn't be told to swim. We need to do better. And there is a body of work that we've done with academics in this province. They are at the University of Western Cape, University of Cape Town, probably also Stellenbosch. And they've done something called a whole system review of the Western Cape. And it is done from 1994 to 2016. And this year, about 4 or 5 weeks ago, we did a 10-year review. So what has happened since 2016 till 2025? And the report is actually interesting. What that report is, they look at the entire system and they say, how well have we done in what we say we're going to do towards 2030? And the answer is, we've made progress, but there's work to do. And the interesting thing for us is the biggest lesson we take out of that is out of this is where the work is needed. And that's why we double down. We continue to work. So that also is something that might be useful for the committee chairperson. If you really want to understand what that external lens is and what the things is that we must try and concentrate on to make the system function better. But to both of you, Member Stevens, the markers that external people are using on whether our system functions well or not, the external eyes are saying to us, our system functions well. There's areas for improvement, but the system functions well. Thank you, Chairperson.
Thank you, Dr. Cloete. I think we've now reached a time where we can get into the presentations, and I'll hand over to, I don't know whom of the ladies will go first. It's Mrs. Brinkman.
Thank you, Chair and members. So I'm going to ask my colleague Samantha Brinkman to then take us through the presentation that will look at the last quarter of 24-25 and the first quarter of this year. As the HOD has already indicated, we will be going today into the details of the indicators and how we have performed against those indicators. But this is just a very small subset of the totality of what we do. A lot of what we do will not find itself in the indicators, which are mostly driven by what the sector determines that we will then look at and prioritize. So there's a lot of richness that lives in these quarterly reviews where we now go into understanding what lives behind the data. And I think we will try and bring a different kind of reflection next year where we will be telling lived stories and less focus on what is actually reflected on the annual performance plan. But that's the projection and the trajectory that we hope to go on to now that we have leveled the playing field and have gained the trust of those who are charged with oversight over us. So with your permission, Chair, then I will hand over to Sam to take us through the presentation.
Thank you, Ms. Kosi. Ms. Brinkman, your baptism starts now.
Thank you very much, Chair, and thank you, members, for the opportunity to present to you. So as mentioned, we'll be reflecting on our quarter 4 and quarter 1 performance, quarter 4 24-25 and quarter 1 25-26. Just an overview of what the presentation contains. So I'd be remiss if I didn't mention the audit. And then, as Under mentioned, we'll be reviewing our performance against APP targets and some comments regarding that performance. So starting with our data governance and our audit, as you can see, it's a a holistic approach. It's not just about systems, technology, people, or process. And this is where I'll take the opportunity to again acknowledge our colleagues across the health platform, and thank you to the services and our compliance team. Of course, even we don't rest on our laurels now. We take our lessons learned and try and improve on them, and share the best practices. Within the department, we are trying to improve on our data processes and automation to help capacitate staff to reduce the amount of tick box exercises, and thereby empowering our clinicians to give more time to our patients and not have to focus on data collection. So that's an ongoing process that we strengthen. And just to reiterate, while systems do support, it is the people that make this work. If I move on to our performance information, so starting off with just some high-level changes to our indicators between the 2 financial years. We saw the measles vaccine has been renamed to MR, and that's because it's a change in the constitution of the vaccine to measles and rubella. We also have a change in our drug-resistant TB treatment. It's a shorter regimen. That's why we're mentioning it here now, because we're hoping that this will improve not only our enrollment in care, but our retention in care for drug-resistant treatment. And also, we'd like to flag that there was a reduction in the indicators, and you'll notice in the tables as we work through it, between 2 financial years. As Anda mentioned, this is not the totality of the indicators that we focus on. There is a wider data set, which is called the National Health Indicator Data Set. But in the APP specifically, we look at the sector standardized indicators as prescribed by national and adopted by all provinces across the country. So if I move on to the slide, you can see there was that decrease in the number. Most of it is, I would like to say, a spring clean, because some of the indicators were repeated unnecessarily across programs, whereas we could now focus specifically on one program holistically across the platform. But there were some indicators removed. We do welcome that as a province, because it does make our monitoring and evaluation against the APP indicators a little bit easier for us, to be honest. But again, to reiterate, these are not the only indicators that we focus on as a province, and we do look at the wider indicator data set depending on the area we're drilling down into. We'd also like to highlight here that when you're looking at achieved, the achievement rate is 100% of target or more. Partially achieved is 50 to 99%. And I'll flag those going through. A lot of our indicators are within the 90% range, which we still consider as a department as a good performance. And then, of course, our not achieved is under 50%. And I'm very pleased to report that we don't have any indicators reported as not achieved target for between these 2 quarters. Something we've changed in the structure of our APP in the new financial year is we've designed our indicators to align with our new 5-year strategic plan and its public value propositions, which are linked to the Healthcare 2030 vision. That is our start well, live well, age well, and run well. So if I start off with our run well related indicators. So this is our support services, which we report under our program 1, 6, 7, and 8. Our one indicator that was partially achieved is our pharmaceutical stock availability. And again, I'd just like to highlight that we did achieve 99.9% of target. So even though it wasn't 100%, in our opinion, it's still a good performance. You'll also notice in some of the indicators we've highlighted where there were mid-year adjustments made in the 24-25 year. These were made as a result of acknowledging the impact of budget pressures, as well as emerging socioeconomic factors which impact health service demands. It's continuation of these run well indicators relate to quality assurance and our EMS. Again, you can see the 2 QA related indicators were partially achieved, but again within the 90% percentiles. If I move on to our quarter 1 performance of our EMS indicators, you'll see 2 of the 3 we achieved over 100%, and the third indicator again was within the 90% range. Flagged by our EMS colleagues was again the challenges with our red zones, hospital limitations, and various data quality issues. In particular interfacility transfers, but they reassure that we are working together to address those challenges. Our quality assurance indicators, the majority are reported in the final year or the final quarter of the year. So we have our patient experience of care rate, which is just actually being concluded at the moment, and that we will be reporting later on in the year. But again, just to reiterate that under quality assurance, although only patient experience of care is listed in the APP, we do focus on our patient safety and SAC1 incidents as well. Looking at our healthcare support services, so here we have our percentage of child death cases reviewed and our percentage of pharmaceutical stock available. We achieved the pharmaceutical stock availability, but again, our child death review board was in the high 90% range. Our other programs, Program 6, Health Sciences and Training, 7.2, Engineering Services, and Program 8, Health Facilities Management, are all annual indicators. So we'll be reporting those nearer the end of the year. But again, there is ongoing monitoring throughout the year to ensure that we are on track. We just wanted to take the opportunity to highlight some of our health platform pressures. As we're all aware, we are in a polycrisis environment. So looking at our quarter 4 performance in 24-25, specifically related to our health platform contacts, we can see that the average length of stay and inpatient bed utilization rate at our hospitals was achieved, where the average length of stay in regional hospitals we achieved 99.8% of target. Compared to our quarter 1 hospital pressures, we can see that the performance was achieved in the majority of hospitals. District hospitals experienced some challenges, and you can see we achieved the 99.8% of target. And we just wanted to highlight here that the lower bed utilization indicates a lower burden of disease and lower service pressures, but we still do acknowledge that this is a high pressure environment. Breaking this down a bit further, we can compare the 2 quarters over the last 3 years. And we can see for our tertiary hospitals, a reduction over the last 3 years in the 4th quarter and the 1st quarter. Central hospitals experienced a slight increase in 2025 compared to previous years. If I move on to our regional and our district hospitals, we can see that the green bar representing an increase in quarter-on-quarter in 2025. And you can see that although there was compared to 2023, it does look like a higher bar. At that particular time, we were dealing with an increased number of substance abuse and mental health clients, which we have subsequently worked together to try and reduce and address. Moving on to our outpatients year on year, this is a quarter 1 comparison over the years. Apologies. So we can see for most classes except district hospitals, the OPD headcounts are reporting a decrease in this quarter 1. Looking at our operations, and this is a total including our complex procedures. And again, we're comparing our year-on-year quarter 1 performance. So district hospitals appear to have recovered to our pre-pandemic numbers, whilst the other classes of hospitals are showing a decrease. This is again due to availability of staff and resources. And hospitals to address this, as well as a revision of reporting and see how we can improve on our reporting processes.
Okay.
Just for a little bit of context on what you see on the slide, the blue bar at the bottom would be the operations done in places like Khayelitsha Hospital, Victoria Hospital, And then all the smaller rural hospitals like Swellendam, they're all classified as district hospitals. In the metro, we add Karlbremer, Mitchell's Plain, and Khayelitsha to the blue bars. So you will see on the blue bars, the operations have more or less come back to where it was just after COVID. The orange bar is the central hospital, and that is only Grootske and Tygerberg. So the orange bar that you see is only Grootske and Tygerberg. And you can see that the biggest challenge of surgical procedures is felt in Grootske and Tygerberg. And that is a direct result of when you have austerity and you have recovery of staffing, it's more difficult to get highly specialized people, and especially highly specialized theatre nurses into an environment like Grootske and Tygerberg. So you can see there's a lag, and that has not recovered. It's actually as low as it almost was during the year of COVID. So there's a big area of improvement of getting our capacity back up at Grootske and Tygerberg for surgical procedures. When you look at the grey bar, that is Worcester George, and in the metro, it is Somerset Hospital. So that's that group of patients. And you can see that's more or less been, so from a rural perspective, that's the surgical capacity in George, Worcester, and Paul. In the metro, it is Somerset Hospital. And that's been more or less like the district hospitals, the blue ones, a recovery. But the point of the slide is the biggest drop in not being able to do surgical procedures in this first quarter compared to first quarters other years is because of Grootske and Tygerberg. That's the point of this. I just wanted to make that point. Thanks, Sam.
Thank you, Doctor. Moving on to our primary health platform context, and this is a reflection of our not only facility and outreach services, but our home and community-based care as well as school health services. So overall, we're seeing a minimal fluctuation between the 2 quarters. And we acknowledge that often some of these services are impacted by campaigns that are ongoing, and sometimes even the weather can impact health-seeking behavior. Moving on then to our start well. In quarter 4 of 24-25, again, you can see majority of those indicators were achieved. We did see an increased number of deaths in our central hospitals by 1. So the numbers are small, which means that any fluctuation does have a great impact in overall performance. And also to note that our pediatric surge season runs from November to May, which may impact obviously on services. Continuing on our start well, we can see the rest of our indicators were achieved. Moving on to quarter 1 for 25-26. You can see some of our indicators were not achieved, but again, we're in the 90% achievement range, apart from out viral load and deliveries in 10 to 14 years in facility. So starting with immunizations, we have identified with facilities the challenges, and we are addressing these by providing additional support where required, and determining whether it is a data issue or whether it is a staffing issue. So ART and TB, our socioeconomic factors and up-to-date contact information to trace our patients remains an ongoing challenge. The withdrawal of the partner funding has influenced our community support as well as some of our data capturing capabilities. But again, we are working on actions to address this. Teenage pregnancies obviously is a concern for us, and we have identified areas in particular requiring further interventions. Just to note that part of the Metro community-orientated primary care approach and the toolkit implementation, they did do community surveys on the priorities as reflected by the communities, and this was flagged by the community as well as being a concern. So we are particularly concerned with the measles performance, as you can appreciate that we have recently had that measles outbreak. This is the most recent data we have from the NICD, and we are awaiting an update. There was a localized outbreak identified in our Khayelitsha sub-district in the Cape Town Metro, with the 33 lab confirmed cases detected. Just to reassure that the sub-district has elicited the public health response that includes enhanced surveillance, risk communication and community engagement. Contact tracing has been initiated, and the provision of booster measles vaccination and targeted vaccination campaigns at schools and creches have been implemented in the Khayelitsha area. We also wanted to highlight our Planet Youth program, which we're hoping will address access to services for our youth and support our interventions in reducing the number of teenage pregnancies. The program is intended to empower communities to work together in supporting young people to make positive life choices and to build brighter futures by creating a safer and healthier environment. Moving on then to our Live Well indicators. So again, starting with our Q4 overview, 2 of our indicators were partially achieved, and that's our maternal mortality in facility and cervical cancer screening. Maternal mortality is again an indicator that's affected by small numbers, so any slight deviation or fluctuation affects overall performance. But we are obviously closely monitoring this as we proceed through the year. And then cervical cancer screening, we have recovered post-pandemic, but there are concerns about the declining trend and the quality of the samples being taken. There is continuous monitoring and improvement, and there is a new method of testing that has been introduced in the province or across the country, and we are expecting this to reduce inadequate smears and enhance detection. We are also working, this is one of the areas we're working on, more digital information, so relying on direct reports from the labs as opposed to clinicians having to report, and we're strengthening that process as well. Continuing with the Live Well indicators, you can see the rest of our indicators were achieved for Q4. I can move on. Our Q1 performance for these indicators, we have majority achieved with the partially achieved again in the 90%. Couple year protection, there were some areas identified that were performing lower than expected, and we will be working with them to address that. But there were no major fluctuations that we could detect in any of the other methods. As previously mentioned, socioeconomic factors and contact details or up-to-date contact information for patients remains an ongoing challenge for our ART clients and for our TB clients, and we are working to address those. Capturing remains a challenge for our viral loads, and especially with the withdrawal of our partner support that did have a knock-on effect. But again, that's one of the areas we're looking to improve on digitization rather than relying on a manual process. We have various reports and initiatives in the TB space as well, action lists that have been developed, again, relying on electronic data that we hope will empower our on-the-ground staff to trace the clients early in their loss to follow-up. We also wanted to note again, that shorter regimen that's been introduced for drug-resistant TB that we're hoping will improve on our success rate. So moving then in summary, our reflections to move forward. Although we celebrate our 7th consecutive clean audit, the work never stops. We always look to see where we can improve and work with our service colleagues across the health platform. We also wanted to reiterate the changes in the APP indicators, and although there is a reduction in the APP indicators, just to reassure that these are not the only indicators we focus on during the year. Our health platform pressures continue or persist, including fiscal constraints, climate volatility, digital threats, and health service pressures. Our support services, we saw that EMS performed well with challenges such as red zones and hospital constraints ongoing and requiring a cohesive response. Pharmaceutical stock availability improved from quarter 4 to quarter 1, and that is ongoing monitoring. The review of our child death cases were lower in quarter 1 due to outstanding histology examinations, which the team will be monitoring and investigating further. Of course, we have to mention our socioeconomic factors, which impact our health-seeking behaviour as well as our means to support in the community. So with the withdrawal of partner funding, that influenced our community support, which influenced our follow-up of adherence to ART and TB treatment. And the full impact of this is still emerging as we progress through the year, but there are various mitigating risk activities that are in progress to address this. So our focus areas are facilities with immunisation challenges that may require further support to determine whether the issues are service or data related, and localised campaigns are ongoing to address shortfalls. ART adherence remains a challenge by socioeconomic factors and outdated contact information, and the compounded by partner withdrawal. But as mentioned, we have those mitigating risk activities underway. And then, of course, the teenage pregnancies, which we highlighted earlier and were reflected by the community, require an implementation of a community-orientated primary care approach and related toolkits. Thank you, Chair.
Thank you very much to our officials. Members, any comments? Member van Minnen.
Thanks very much. This is a bit counterintuitive. Essentially, I've got a question about some of the indicators and performance numbers. Unfortunately, the slides aren't numbered, but I can just talk to it. For example, here, number of DSTB treatment starts under 5 years. Target is, say, 681. Achieved was 856, 125%, 0.7, so it's green. There are a number like that. My question is, I understand you have a target, and if one achieves higher than the target, it's green. I get that. But does it indicate, apropos the conversation we had earlier about a good healthcare system, is achieving a higher result than the target indicating that there is, in fact, a bigger problem than one thinks, if that makes sense? Wouldn't achieving it in a way be that one only has lower incidence? I mean, okay, I'm linking treatment with incidence, which I understand is not the same thing. But do you understand what I'm saying? Is achieving green indicating a crisis that one's going to have to face, or not? And how do you determine that? Do you understand how I'm trying to relate them? There are a number like that, a couple of pages on as well, with, well, here, again, the TB treatment, multi-drug resistant success rate, mental disorder treatment rate, getting 107%. Is it indicative of a larger issue? Thanks.
I don't see any other hands, but before we respond, Doc, I want to go back to Member van Minnen. You just came with a very interesting approach. And I've been thinking, because if I see green, I go like this, you know, and Member van Minnen have a different approach in terms of what might be the underlying factors for green. Now, my question at the same time, just to piggyback on that, what if there was a red? What would have been your question? I'm just thinking, like, what would have been the underlying if there was a red instead of green? I'm just piggybacking on you, Member van Minnen. It's very interesting. I'm going to now look differently at colors. There's now.
Member van Minnen, that's a very interesting question. When I tried to explain last year to the scoper what the challenges is with the convention of setting targets in the context of sector-determined indicators, you are touching on one of the challenges. I don't think I succeeded in explaining it clearly in Scopa. but I'll attempt to do it in this way. So there's two things that goes into the target setting. So you got that page that you refer to is actually quite useful because there's a few targets there that actually you need to understand what the target is intended to set. So if we take HIV positive 5 to 14 rate, right? So HIV positive for 5 to 14-year-olds. And we say that our target is 0.56%. And we achieve 0.45%. So what happened there is, with our interventions, there's a baseline of how many people were positive before. And now we're saying we want to do better. And we set our target like that. So if we are getting fewer people positive, we have overachieved against the target. So now there it says 124% achieved because we tried to get the positivity rate to be lower than a certain point. Now it's lower than we set as our target, and therefore we're overachieving. So what you're seeing is you see 124. Now, rightfully, by that convention, if that was 0.25%, it would have read 200% overachieved. So the question that, Minister, if I suppose from that specific indicator, it's the sensitivity of us looking into a crystal ball, putting a whole lot of stuff together and saying, this is how many people are going to come forward. This is how many we think is going to be positive. This is our intervention putting together, and therefore we set the target. So sometimes we're going to overshoot, sometimes we're going to undershoot. The question is, when we read it, we need to understand what it is. What does overshooting mean? Now, in this case, if we are overperforming, it is good because there's fewer people positive. But if you go to the next one, the number of DS treatment people started under the age of 5, which is the one that you chose, we felt that we want to start 681. Now, rightfully, we started 856. So that is significantly more than we thought we were going to put onto treatment because we had to put people on treatment. So now the question is, we actually found more people and put more on treatment than we thought we were going to do. And the question that you're asking, isn't the problem bigger than what we thought when we set out? Now, this is all the things that must go into when the result comes out. And it is important that we ask those questions of one another so that we have an understanding of what lives there. But if I take you the next one, this is my favorite one, because I tried to have a conversation with Professor Hausum many years ago. Say, Professor Hausum, this thing just doesn't make sense. Here it is. We must predict, we must set a target for how many people are going to die because of diarrhea. Now, I'm like, how I'm going to look into a crystal ball and say to you the diarrhea is going to be so hot in February, or it's going to be maybe low, and so many people are going to get diarrhea, and some of them are going to come to the hospital, others are not going to come, and this percentage is going to die. It makes no sense to me to set the target for how many people are going to die because of diarrhea. He said, well, you just do it because that's what we've been asked to do it. So here we say, we want 0.37%, right? But what happened is there was 0.34. So again, we did a little bit better, but this is a completely different target setting to finding people to put people on treatment because this is an outcome of how many people are going to die and put it there. But thank you for picking it up because that actually, Chairperson, member from you picked up the issue of why the target setting and the convention we use needs to be, it's a complex set of things that goes into each one of them. And thank you for highlighting how it is, because the next one is people die of pneumonia. And then the next one is severe malnutrition. So it is important for us that we are, you can see from these indicators, it is not over 200%. If it's over 200%, you can ask us, your target was a little bit off. What we've done here is, for every one of that, whatever we set as a target, there was a better performance. And that's why it's green. And that's the point, Chairperson. It's a better performance. But what does a better performance mean? And there's an underlying question that Member Van Binnen has asked. So thank you for asking the question. I can go through to the entire list of 41 indicators and actually tell you that that is the thinking. But thank you for bringing that lens into asking that question to us.
Now it makes sense to me as well. I now understand. In the absence, while the other members are still, Member Van Vogel.
Thank you, Chairperson. Chair, I want to welcome the presentation. My interest in yesterday's budget meeting, it was said that in health there is a lot of job losses, and it's actually happening every quarter. So I want to understand, is it perhaps related, because I'm not aware of during this time, or is it perhaps related to people resigning or retirement? If I just can get clarity on that one. Then on slide 7, is it slide 7? You just explained, Doc, in terms of the performance, but I want to understand on slide 7, the reason for the poor performance for that indicator. That's on slide, if you go to slide 7. Yeah, it's partially achieved.
Maybe if you can just lift up.
Yes, yeah, that one. And do you have an improvement plan when it comes to that? Then on the also slide 11, that's on the ideal clinics. How is the ideal clinics status improved when compared to previous financial years? And if you can indicate where do we find them? Is it more in the Overberg, in the Southern Cape, in the different regions? And then I also see there's a lot of achievements when it comes to EMS service, especially in the rural areas. Can you tell us more about the measuring systems used? Because we know there are a lot of challenges around ambulances in rural communities where we come from. I will park there for now. Thanks, Chair.
Dr. Klute, maybe because I was also in yesterday's finance meeting, just to add on to your question in terms of the job losses. I think where that might emanate from that question, there was a section in the finance presentation yesterday where there were the offsets between over expenditure and the offset again, the COE, that reduced it. So it was in that line. Okay.
Thank you, Member Van Vogel. So that context, if that is the context that the chairperson explains, that is something that we try to explain to you as a committee. It's remember when we talk about 24, 25 coming to an end. So if that is the finance presentation of what happened in 24, 25. So up until March in this year. If you remember 24, 25, we went through a situation where we had significant resignations in the healthcare system for us because of a two-part system that was somewhere in July, August of the previous year, in 24. And what we normally measure in health is how many people resign plus or put against how many are we employing. So we noticed between July, August, September last year, the number of people we interviewing and appointing was much less than the number of people leaving. So what we reflect is then the net of posts. And because there was this, that was only one factor. Because this came in and the two-part system basically made people feel very anxious. Many people resigned. It was more disproportionately felt in nursing, and because it's many people that has worked for slightly longer than others. Right? So it's people with longer terms of service. That was the one factor. The second factor is, at that point, our APL, our approved post list, we didn't have enough money to expand post a lot. But we did come in the adjustment estimate and say we wanted to protect our posts. So you remember Minister Wenger saying to you guys, we want to protect the posts. So we were still trying to protect the post, but more people left than we could put in. And then the third thing on top of that was the regulations from DPSA made it more difficult to recruit people. And that is, something that we had before, which was called a block advert. So for production people, for doctors, nurses, you just had an open advert. People resign, you can just interview and appoint. Now we had to go through for every post. We have to advertise it and advertise it nationally. What we get in response to every single post, like there was an example, Grootske made an advert for a cardiothoracic surgeon. We had 1,200 people apply. Not a single person had the skill. So what you had to go through, you had to go through shortlisting, go through all the CVs, do all of that things to get to the point that you must go to interview. 2 people are potentially there, but they don't even have the skill. Then you have to re-advertise again. So just to give you a sense of how all of those things play together. So remember Windvogel and Chairperson? What you would then see is because we wanted to protect the post, we made a decision. We want to continue having the post, although we couldn't fill the post. More people left, and we couldn't fill the post fast enough. You asked us in the adjustment estimate that we came to you, and we made the case to you to say, because we can see till the end of March, we are going to have a significant underspending on post because of those factors. We then shifted the money from post to goods and services. And this is the conversation we had with you when we had the adjustment budget tabled. Now, what Treasury is just giving you back is the result of all of that. By looking back, health moved money from post to goods and services. Therefore, there was a reduction in the number of people that was employed in health. It just gives you that context, if that is the context that you're asking. Does that make sense, Member Bedford? Okay.
That's for me, Doc. Thank you.
Okay. So the next question then about slide 7 about pharmaceuticals. Sam can just find the slide, because further on, to answer your question directly, in Q1 of this current financial year, we actually overachieved against pharmaceutical. So this is the one you're saying that is 99, let's say, 9, and you partially achieved. But in Q1, there's a slide where she showed it's an 104% in Q1. So if you go to the next, the one on Q1, you'll see that that same indicator is 104% in the first quarter of this financial year. So quarter on quarter, there's been a movement from 99.1 to 104. So it's gone from yellow to green in the 2 quarters. Is that sufficient? The issue about the idle clinic is an important question. And if I understand your question correctly, the ideal clinic, we probably will be justified. I'm not sure when last, Chairperson, we gave you a report on the ideal clinics, but it might be justified to answer the question, to say to you, this is our performance ideal clinic year on year. And also, and it will come up in the annual report, actually. When we do the annual report, we will have that conversation. So if you don't mind, we can in the annual report give you the more detailed answer. We can make a flag and then prepare for that answer. But long and short is our ideal clinic performance has steadily been increasing year on year. And we do have performance across all the districts. And obviously in certain districts, there is a slight better performance than in other districts. But to give you that information offhand, it would be important for us just to understand where it is. But mentioning Overberg is one of the districts which normally performs well in things like the ideal clinic. So it would be useful to show you what that is in a little bit more detail for the annual report. And then the last one, the EMS again, it's the factor of the way you ask what the measurement is. So you will see in the EMS that the measurement is EMS response time, rural response time, under 60 minutes. So if you are in the metro, right, urban response time, we say it's 30 minutes. If it is in rural, because of distance of towns, we make it 60 minutes. So it is from the call being made and somebody arriving within 60 minutes for a specific urgent call. So if you call somebody and you say, well, you know, I've had a backache, and that call gets classified as P2 or P3. If you say, I've got a chest pain, I'm short of breath, can't breathe, the person's blue in the mouth, that sounds like a heart attack, that's an urgent call. That's a P1 call. So the P1 call is those urgent cases. And in the rural, it is within 60 minutes. And you will see that the performance there says that the target was 77%. And in 78% of cases, we got to that person. So again, like I explained to Member Van Minnen, we overachieved of 102%. It's green for that specific one. And then mission time is an interesting one, because mission time is when you are, from the moment you pick the person up to the moment the person is actually in care. So mission time measures whether somebody's been picked up, whether somebody's been dropped at the health facility, and whether that person is now receiving care, so that the EMS guy can leave. So mission time includes how long it takes you to pick up the patient. So mission time is very much influenced by, if you drop somebody at the clinic, whether there's somebody to accept the patient. Now, if there's a delay in releasing the ambulance, you're holding the ambulance back from doing something else. And we want the mission time to be as short as possible. The mission times go very high when you have to pick somebody up at the health facility, like a clinic, and drop them off at the hospital, which we call interfacility transfer. Now, the first thing is you need to get to the clinic and actually find the person that calls and said, okay, there's the patient, hand over the patient. Now they're busy in the EC and they don't have time to make the ambulance guy wait for 15, 20 minutes. The worst thing is he takes him to a hospital. You arrive at the hospital is busy. Nobody's around there to accept the patient. And that can lead to about 15, 20, 30 minutes of delay. So if your mission time goes higher and higher, you take ambulances out of circulation for urgent cases. And that's why we measure mission time. But even in this one, we said that our mission time should be under 120 minutes. So that should be under 2 hours. And we said our target was 47%. So we wanted, but we achieved 48%. Obviously, you can understand it would be important for us slowly to increase a mission time under 2 hours to 50%, to 60%, to 70%. Because if we do that, we free up more ambulances to respond. Hopefully that explains it, Member Van Vogel.
Member Stevens.
Just to come back to Member
Van Vogel.
Van Vogel's question regarding the staff shortages. As we know, the staff shortages are the biggest contribution to the poor service delivery and inability to assist patients timelessly. What measures are in place to urgently recruit and retain and support healthcare professionals to ease this burden? Because it is a burden at the moment all over. Thank you.
Thank you. Yes, Doc.
Member Stevens, I'm going to do something. I hope you don't mind if I do it. You made a statement of fact. And I'm a person that have gone to a health facility, and I said to the person in a health facility, you say that poor service delivery is because there's staff shortages. So you've made it as a statement of fact. Poor service delivery has got many factors. It's not only because of staff shortages. That's the first point. So poor service delivery has got multiple things. And actually, when I went into this facility, and this is Kleinvlei, I asked the facility manager, so what if you had 6 more staff members at this facility? Where would the patients go? Because every corner of that place is completely packed. So because people say we need more staff. So I said, okay, so what if 6 people arrive? Where are they going to sit? Where are they going to see patients? So it's also the mindset of the people working in our facilities. And it's not judgmental. I'm not doing it in a judgmental way. But we're asking people to think slightly differently about it. So when I ask them, okay, so what's the real reason why there's so many people sitting in the waiting room? Oh, well, if that facility did something better and whatever, maybe fewer people will come. Okay, shouldn't another facility have more staff members than this facility? So that's just the complexity nature of where we are. And having staff at the right place is the answer. Having more staff in overcrowded facilities is not the answer. And I can tell you that, Member Stevens, because I worked in Mitchell's Plain Community Health Center 30 years ago. And we were 6 doctors. And there was something like 40 nurses. Mitchell's Plain Community Health Center now has more than 200 staff members. And it got built on and built on and built on. And actually, as doctors 30 years ago, we said, actually, just let the people in the city clinics just see more patients in the drainage area. Don't make it just plain CHC. And this is 30 years later. So there's complexity that's lying in this. And our plan is to actually address the system issue, to make the system function better. Not just to say, add 15 staff members here, add 15 staff members there. It's looking at the complexity of all of this. I hope you don't mind giving you that answer. Thank you.
You're much cleverer today. The questions being asked and the answers. I'm going to be a brilliant chairperson. Member Van Vogel?
My mind is a type of follow-up on the EMS services. And I want to also delve into, I'm not sure how you call it, the forensic people who pick up dead bodies. Yeah. So I just need clarity. Are you saying then the turnaround time to come, let's say I make a call, is nearly an hour. It's an hour, 60 minutes, an hour. For, let's say, I was in an incident on Saturday morning. My neighbor's son went to the location. He was stabbed dead. So I was standing with the body for more than nearly 4 hours, laying there. I have to call. I tried to get hold of Dr. Kluti, but I got hold of Dr. Karim. And he assisted at least to because it becomes too much for a family to see a body laying there for nearly 4, I think it was 10 minutes, then it could have been 4 hours. So I want to understand in terms of their turnaround time, because they call the ambulance. The ambulance, remember, is not far from the location. So why is it still taking that hour? That is an emergency. So doesn't matter where, or does it only depend on the type of situation when it comes to the hour? So I really need to understand that because it's really not a nice affair when you look at the response of the EMS, and then also when it comes to the forensic people. Understanding that the forensic people are not based in Swellendam, but at least the ambulances is around.
Member Van Vogel, that's again, I mean, it's similar to the question that you asked from that Member Stevens asked, and I'm going to give you a similar answer. So you've just described the day-to-day complexity of managing, let's call it the emergency call out. So when that call comes in, the person must decide, is this a P1, P2, P3? P1 is, I'm going to go to that site. And if I get to you within an hour, I've got a chance of getting you to a health facility because it's important to save your life. That's what P1 is. Somebody calls and says, we're calling you, but the person is dead. That's not P1 because you're not going to save that person's life. So all of a sudden that goes in the EMS realm. I'm going to prioritize a call where I'm going to go to somebody to pick them up, to get them to a health facility to be saved. The complexity of that
is not going to drive 120.
Yeah. and should be within the time limit. So so what that then goes, it is the complexity of now that there is a dead body and there's a scene. The dead body in the scene is that for FPS, which is now Forensic Pathology Service, to be deployed to that center, that call gets like automatically put to FPS. FPS cannot interfere with that scene until the police has secured the scene. And in most cases where people have contacted us to say, well, we've waited 4 hours for FPS to arrive to pick up the body. FPS can only be deployed if they get assurance from the police, because it's only the police that can trigger the FPS. Now, you might, as a family, have called, but the FPS is not waiting for the family to say there's a dead body. FPS is saying, now we're waiting, because SAPs have to call us, because we've heard somebody say there's a dead body. If we arrive on the scene, which has happened to an FPS member in Mitchell's Plain, that's the Mitchell's Plain that weekend with all the shots, then the FPS person gets assaulted because the police hasn't arrived. And FPS cannot remove the body. And he said, well, I can't remove the body because it's not been secured. That FPS guy was proactive. He heard about the shot. He heard the call. He went. And then the people assaulted him because he said, I can't take the body because the police hasn't been here. So that's the complexity of a death scene securing, and that the police has to do it. In most cases of the 4-hour wait, we go back and we check how long FPS gets to the scene. Invariably, it's 30 to 45 minutes from the time that the police activates and say the scene has been secured. So hopefully that explains the situation. And I know I've been involved in many of these calls, and I'm sure that's what Dr. Karim facilitated on the day, because we normally send it to the FPS guys. They say, well, waiting for the police, we'll make sure. And then we get assurance, like within half an hour, there's been somebody, the body's been removed. But the main thing that happens there is the securing of the scene. It's a death scene. It's a criminal scene potentially. And therefore, nobody is allowed by law to interfere with the scene. Not somebody from FPS to come pick up a body and put it and take it away. Thank you.
Follow up, Chair. No, I do understand the dynamics explained by Dr. Kruti. I just brought this thing of the dead body in, but this boy was there, alive when we arrived there. He was alive. And then somebody told them they can't take the body with a car to the hospital. That was the other issue. So they called the ambulance and they are waiting on the ambulance. So I do understand the forensic. And then I engaged the police. Even they are saying they already informed the forensic. They are just waiting for them, to come and pick up the body. Yeah. So yeah.
Doc, on that, all of us in here, we stay in townships and whatever, and we experience these things. And I was confused at one scene exactly on that, should I load the victim into my car? What do we do? We don't know.
So I think that, and that is probably what happened on Saturday, and it happens often. So somebody is fatally injured, but they're still alive. So in that instance, the call is to EMS. The performance here, if it's in rural, we must get there within 60 minutes. If it's in metro, we have to get there within 30 minutes. Now, that is the question that you ask. When that happens, unfortunately in our system, when it happens in a weekday, 3 o'clock in the afternoon, we're likely to get there within 30 minutes. Moment you hit Friday evening, 10 o'clock, till Sunday evening, 12 midnight, 3 in the morning, that period, there is a spike in calls for ambulances to go to all kinds of places. And then on top of that, it's not just the spike in calls because of the time period, it's also the geographic area where you find yourself. Because the pressures are not equal across all of them. If it is an area where there's an escort required from because red zone, that's already an hour added because you wait for for the police to accompany. But it's not an excuse, Member Van Vogel. We actually can pinpoint those situations, and Mr. Nick Newman is the guy that actually then follows up on this. And I've seen Nick Newman go to families, sit with them. I've seen him go and talk, and he brings it back into the way people then respond afterwards. I hope Nick is involved with this case of Saturday, because what he will do is he will then go and say, okay, who was the unit that was closest? What went wrong? Why couldn't that unit be redirected? He does all of those things and then come back and say, what is the improvement that we have to build into our system? So again, it is a very, very, my heart goes out for the people on the scene that has to deal with it, because you feel helpless. There's urgency and nobody comes. So it's a real thing. And we probably will go back and I will have a conversation with the colleagues between FPS and EMS to say, for that situations, what do we do? How do we actually create almost like you called, nothing, no response. Is there an additional call, and how can we actually deal with it? But it's a real issue and it's a real concern for our own staff in terms of that, let's call it community situation. The biggest thing that we are suggesting is the best way to deal with it is the first responder process. Now, again, you don't want to make community members responsible for all the ills of society. But the first responder that at least can come to a scene, that can stabilize, that can say, okay, this is how it is. So that is the EFAR program, the Emergency First Aid Responder, and the CFAR program, which is the Community First Aid Responder. That's why we have a whole training program for people. It's like people in the old days that used to have St. John's training, but it's having those first responders. And probably in the hotspots, Member Van Vogel, it's something that we have to make sure that there's more and more, and people are locally aware who is the first responder that can actually calm people down. And the first responder would have direct access to EMS anyway. And then you can, work around it. So there are attempts to deal with it, but we really feel it with the people that's on scene that has to deal with the complexity as it unfolds. And most of the calls I get is because of somebody on site that has to deal with the situation in that way. Thank you.
May I make a suggestion? Because I do know that we can go on forever and ever based on personal experience, but I want to just add something, and probably members, maybe, we should have an engagement just to understand the general stuff that goes on with this, because just to add to that, we're not going to harbor the point, but when one way or another, when we have such an item, where we can just engage, and just as homework, because you've raised you've given an answer of first responder, and to me, I understand that, but again, we go blank when we personally on the scenes, we just go blank. And what I'd like us, as homework, Dr. Kluter, you and the team, when we're gonna have the general, because we need to give leadership as well when we're on the scene. For instance, there's this belief, and it's a catch-22. On the scene, we're from rural areas, we have cars and whatever, and then there's this belief that if you bring in a victim by private car, you're not going to get attention quick enough at EC than an ambulance. And then there's also the belief that because of the distance, we're 100 kilometers away, we want to take the ambulance halfway. Now, the questions is all of these things advisable, So going forward, we need to have these discussions, because people look at us, you're an MP, must know everything.
Listen, just one last point, because I think it goes for ward councillors, it goes for any member of any politician in any geographic area, that you become, in a sense, a community first responder, because you are being called upon to respond to incidents like this. And I do think it is to be very mindful of us to actually take this committee through what that should look like. Because, I'm a trained doctor, so I've been trained to be a first responder. So if I'm driving in my community and somebody calls, my first thing on the scene like that is just to calm everybody down. I do very little else. And then to say, is it going to be advisable to put this person in a car, or is it better to wait for the ambulance? And the issue is stabilize the person on the scene, wait for the ambulance. But it's situational. You know, some other times I might stop and I say, actually, let me just put the person, we have a bucky, there's a straight thing. I am a medical person. I'll get in the back. I'll accompany the person, because the biggest thing that happens is your own liability that you put yourself at risk in. The moment you put that person in your car, there's a liability issue. Because if something happens to the person in your car, you took upon yourself to operate outside of your scope, and the person died on your watch. So it's all of those things, which is a little bit more complex than all of it. And I do think it's incumbent on us, and it's good to have a conversation about understanding all of these. So,
Member Walters.
Yes, Chair, as I raised my hand, one part of what I wanted to ask was covered. I wanted to ask about liability. To what extent does liability affect, call it responsiveness? I fully understand people, especially who deal with the lives of people every day. There has to be it's reasonable. Is there a space, and is there a problem perhaps, and is there space perhaps in that first responder situations, especially in situations like that where it's complex? You know, you have it's not just the medical component. It's there's the stabilization, there's the dealing with the situation as it is with upset individuals. I think in any death there will be, whatever the context, there will be. And all of us have been exposed to that types of situations, and I had one very bad experience and one that was better. But the key thing is, I always thought it's one of those situations where or a situation like that, there has to be somebody in charge, not just of the responsiveness, not just the. If there's a forensic situation or there's a crowd situation, there has to be somebody in charge. How we solve it, I don't know. I don't think we're going to solve it in this meeting, but I think there's a need for it, Chair, and I just would have liked to hear. I see from your nodding you agree, but I just would have thought, wanted to hear your views on that particular take.
Dr. Prote, then we'll wrap this up in terms of the personal experiences.
So thank you very much, Member Walters, because I have gone out on a Friday night with our EMS and the medic first on call. And there is a system between the EMS guys and Member Windvogel and Chairperson. The reason why people say don't put the person in your car is because of this. So the system that exists currently, if I go on this Friday evening and I go on that, and there's a call that comes in, and normally the first person that's on the scene is law enforcement from the city. Because they kind of, and when they arrive, it is just to say, you know, just guys, just cordon this off. There's been somebody knocked over as a pedestrian, or somebody has been stabbed, or something happened. So law enforcement, when we got to every place we got to about 12 places in that Friday night. Every time we arrived at the place, at least law enforcement was there. And even our EMS guys are on the same bandwidth and, you know, the thing where the incident is registered. So it is important that somebody secures the scene. The situation of what happened in the scene then dictates who takes charge. So there's a securing of the place. And then who takes charge? If it's a medical emergency, somebody that's senior enough, when you arrive there and there's 15 people on that scene. We came to 2 car crashes on the N1, on the N2. So to get to that place, and there's 3 people caught in the middle under their seat belts, and it's a matter of jaws of life must come out, because that person at best have maybe 20 minutes, otherwise they're dead. Then a senior person that comes on the scene, and that's why I say when I used to still be clinically active, one of the things I used to do, because I did it in the EC as well, is to then create the calm. Because from a medical perspective, somebody takes charge. And it's normally the kind of control medic or the person that arrives after the law enforcement has put that there. So there's a whole lot of thinking that goes into it, and a whole lot of processes and systems go to it. The problem is that's on the N1 and it's on the N2. And then there's 3 calls at the back of Kailicha. And then there's 2 calls further away. Then people are stretched because then they are unguarded sites. That's the kind of thing, and it's almost conflates at that point. But your point is absolutely correct. There's liability. There's also securing the situation, and the role of first responders in that would be important. But somebody must take leadership to make sure that things are in an organized fashion.
Members, I like this discussion, but not for today. And I do believe we must come up with a way when we done with stats and finances and what is it called? KPAs and KPIs. When we're done with that, we need a session where we just deal with this, because then in our public meetings, we can also start, conveying in so that people know when these things are happening. Any other non-personal experience, members? Member van Minen?
Thanks. I just want to ask a question about the issue of teenage pregnancy. Just going through everything here. There is often a call for reporting of teenage pregnancies when that girl is under the age of consent. And there is often pressure brought to bear, particularly politically, for a reporting system in terms of the criminal justice system. Can I ask you, from a healthcare perspective, forget the other issues, from a healthcare perspective, would there be unintended consequences of that in terms of girls accessing healthcare and essentially making sure that they have medical treatment? Thank you.
Dr. Cloete?
Thank you, Member van Minen. This is a crucial question. And remember, we said we look at the data line and we tell an in-depth story. This was one of the in-depth stories that was told from a specific area. And it happened to be the Overberg area, where Trevor did a story from that area. And it's a fascinating, the arena is fascinating from a legal perspective. And then it's fascinating from what the regulatory environment allows and what the role of health is within that. So the primary thing for any healthcare worker is we cannot deny access to medical care for anyone under any circumstances, irrespective of their age. So our basis of providing medical care must be unbiased, must be with one primary aim in mind. It's in the best interest of the patient that we must serve. So one of the stats that we pull up is we have 12-year-olds giving birth. So a 12-year-old, now firstly, the question is that you're asking, if you're 12-year-olds, it's evident that by law, that is statutory rape. Whoever had sex with the child of 12 is statutory rape. Then you get closer to 16, it's still statutory rape under 16. If you go over 16, then the laws change and there's consent. It's the ability of the person to then have consent. But up to 16, strictly by the law, anybody that's pregnant under 16 is statutory rape. The healthcare provider at that point cannot have the entry point providing care from a statutory perspective. The healthcare provider is for your health. You have a pregnancy, we need to assist you and make sure when you have counseled the person and you have worked with that person, somewhere in that, because one of the concerns that we have is, has the 12 to 16-year-old disclosed to their family that they're pregnant? Now you get the point where people don't disclose, they come in late and they have complications to the pregnancy and then you have to deal with it. Or they go for backstreet abortions, which still happens, or they come to us and say, we want a termination of pregnancy. So all of those things play together in the healthcare space. Our primary thing is what is in the best interest of the physical health of the person. We do get to the point where we've done all of that. We will deliver the baby, we will have to have compassion, or we will do the termination of pregnancy, because you actually can request termination of pregnancy without your parents' consent in that age period. Once we've done all of that, and this is one of the case studies, again, a story was told, where we say, actually, We were concerned about the well-being of this 12 or 13-year-old with her baby because the father is an older person. The family does not approve of this relationship with this person. Where does this person with the baby return to? And to get reconciled with the family, then our social workers get involved. It was a very, very hard rendering story of what they had to go through because they actually had to go through with the family accepting the child with her child back. And this older guy was taking advantage of the young girl and go through the process of having to have the procedures followed for statutory rape, which in the end she dropped the charges. The family then accepted and all of that because it is so complex in the local context where the person lives that these things come together. But thank you for asking the question. And from a health perspective, our primary aim is the physical well-being of the person, but it opens up societal questions. So when we have a line that says 59, 10 to 14-year-olds give birth, we have to say to people, this is a public awareness issue. 10 to 14-year-olds in the best circumstances should not be giving birth to babies. What are we doing collectively about it? And that's why Samantha also mentioned something called Planet Youth Chairperson. And we've just gone through a survey of 49,000 13 to 14-year-olds in 49,000 in 121 schools. And we asked them general questions about their well-being. And now there's an opportunity to go into communities where we've done the survey to say to the parents and communities and everybody, what are we doing about our 13 and 14-year-olds and how do we respond to the findings? And you can imagine what some of that results is. But one of them is how do we make young people live protected lives and look after themselves and all of us, because substance abuse is big, violence is big, exposure to other risks are big, and how do we collectively protect the young people? Thank you. Thank you.
Member,
It's my last question, Chair. I totally forgot. I want to mention this. We had an oversight before going into the question in Ceres Hospital. And there's a huge improvement when it comes to services. And I'm just wondering, when I was there the last time, I felt like crying when I engaged the patients. But this time around, there was calmness, empty waiting rooms. There's few people, but you can see things are happening. Are you perhaps, do you have that interaction with these different hospitals where they share best practices? So you do have, okay. Then, because really that was something to, you do an oversight visit and then go back, same thing, it's still the same. But with this one, it was different. So I need to compliment the department when it comes to Ceres Hospital. Remember, it was a long story. It's coming a long way. Then the other thing that I pick up, and that's one thing I think as the committee must not shy away, is that our responsibility is to do oversight over the executive. And something that I pick up there is when we do unannounced visit, it's like an if seniors are saying we must inform them when we do unannounced visits. And it's not the case. It's I'm get paid to do that. So I just want to touch on that issue. Then lastly, Chair, Doc F explained, I'm not sure which slide is that, the operational total, including complex procedures. I think the surgical procedures. I want to understand, Doc, do we have a plan? Because you explained the reasons and where the problem is or are. Do we have, what do you call it, a turnaround plan of, in terms of how to deal with it, so that we do have, specialized people? Do we have it? Then lastly, under, I'm not sure because there's no pages here, but it's saying Q1 FY 25-26. the child under 5 years severe acute malnutrition cases. I want to understand in terms of the in terms of the, what do you call it, fertility rate? Because that's the interest, because what I pick up is ons dog alles is okay dolle. If when you go down, and actually during my door-to-door, I realized a lot of people are hungry. The hunger is live out there. So I want to understand that, and that's all for now, Chair. And is there any debt when it comes to muscles? Do we, since remember you are saying in your report
Yeah,
that
right.
is from January up until September. Thank you, Chair.
Member Stevens, do you have a question? Oh, okay.
But anyway, thank you, Chair. I just want to know performance assessments on the facility managers, especially the day hospitals. How often does the department do that? I'll make an example. You know, most of the communities now, if you go on Facebook, on social media, they've got community groups. And if you go on that one specific group, the Cry Fontaine, they call it Cry Love. It's actually sad to read there the people's experience with the Cry Fontaine Day Hospital. And I also got very bad experiences there, because sometimes I go there when people phone and say they're sitting for 10 hours, 12 hours, 2 days for somebody to help. And I walk in there quite a few times. It was in the middle of the night or early hours or like during the day. Then you will walk in there. Okay, security try to stop you, but when you go in there, there's enough staff. There's enough, more than enough staff, enough doctors. And there's a certain time when they just stop working because they're waiting for the night shift to come in. They stop working. And like when you try to reach the manager, especially in the one in East River, come to think of it, the manager's never available. Either he's on lunch, the facility manager's on lunch, or he's somewhere. You wait there 2-3 hours, doesn't pick a rock up. There was a time now when people were sitting very long in that dome outside without help. Not a lot of patients, enough staff, not a lot of patients. Where I suggested the other night the patient found the facility manager. Then the facility manager made one phone call, and that man's wife was helped because that woman was dying outside in the dome because they were thrown out of the inside of the hospital. They must go sit outside in the dome where there's no doors. It's so cold in that dome. And that is the thing that's happened. Sometimes there's really cases that can be prevented, but because the service is sometimes bad and there is really enough staff, but I don't know, I think some of the staff also, they just go in there for the salary, not for the patients. And if you go on that group, it's like sometimes people mention our names, saying, but we've got an MPL here, or we've got councillors here, but they do nothing. What more can we do is to go and see what's happening. And like, yeah, when it's like 2 hours before shift ends, nothing happens. And then there was a time when I also walk in there, asked them, why don't you assist the patients? They said the reason why they go, I call it the go slow, because the hospital is full, Calbrema hospital is full. So they decided to go in a go slow at the day hospitals so that they don't have to send patients to the hospital. There's a lot of patients sitting there that doesn't really need to be sent to the Calbrema or Tygerberg Hospital, where they could assist their patients and let it be people go home. Now they taking their own time helping the patients that they could help and send them home. Now everybody must wait. People with small children, old people must sit outside in that cold domes. Nobody to help them. People literally sit at the Cry for the hospital sometimes for 2 days before they get assisted.
Thank you,
Thank
member.
you.
Before you respond, Doc.
It's crazy.
Yeah, no, I can imagine that. I'm a nice guy and I want to maintain that title of being a nice guy. And members, I did promise and I now want to make a commitment, and I've made 3 notes here that there are matters that we need to agree on where we will call the department and we just engage, on these matters, because I do get the sense that we have burning issues, because we burned our fingers. And I just want to mention this, members, so that after this, maybe through the submissions as well. For instance, member Walters on his agendas, he always has any other business. So I do think that we're going to reach a stage with what came out that we deal with any other business. Just to make an example, and we're going to stick to this going forward when we're done with the professional star issues. How to react on an accident scene and an emergency, just to engage. We're going to deal with that. Secondly, what also came up after Member Van Minden's question in terms of what should happen, because we see statutory rape with our eyes. So there are legal requirements to that, and we never deal with the legal requirements. And it's not just health, there are social development, there are other departments as well. So that is the second point, but we're going to deal with the health responsibility, as you alluded to, Dr. Klute. And then what you now just mentioned, Member Stevens, another thing that we just need to discuss without having, a pinpoint presentation, PowerPoint presentation, a conversation. The third point on the conversation is triage, because we also have that issue where who must sit 5 hours, who must sit 10 hours. We need to have those conversations, and probably on Monday going forward, we just need to have a conversation, so that we can take it from there. So, Doc, can you respond to that? And then I'm going to wrap it up. Next time we'll have a conversation. Thank you.
Thank you so much, Chairperson, and excuse my exuberance to want to respond. So,
Maybe so that I don't take you back. Also, the issue as part of your last response to this, because the term red zone came up a couple of times.
yeah,
And in Member Van Minden's meeting last week with the police, they also mentioned the red zone issue.
absolutely.
And I think it's not a silver bullet
No.
issue that's going to be resolved now, because they are saying, SEPs are saying, when what's it called? Cash in transit, heist, or whatever. They're saying, and we all know there's always a shootout on those scenes. And they're saying even if somebody is shot in the foot, the moment he falls down, they're not going to touch that person like what you said. They're going to wait for an ambulance. Now they call an ambulance, and an ambulance is saying, it's a red zone, can you come and fetch us?
Exactly.
So it is a chicken and egg thing. And they don't have the resources. They don't want to leave the scene to go and fetch an ambulance. It's got to be part of the conversation. Thank you. Wrap it up, Doc.
Thank you very much, sir. So, Member Windvogel, the situation with Ceres actually is a very useful counterpoint to discuss the question that Member Stevens asked. Because Member Stevens, everything that you just said about Kraaifontein is what everybody else and more said about Ceres 18 months ago. So there's a counterpoint between the two. So just to explain what happened in Ceres. In Ceres, we did not take a punitive approach. And this is part of our point of departure. We have to believe that everybody that's in our system is trying the best that they can do to do the best with the circumstances where they are. So we gave the people at Ceres the benefit of the doubt. You can ask Member Windvogel, we didn't change management. It's the same management. 2 years later, she says she can't recognize the place from where it was. All we decided to do is we tried to support. Not to be punitive, not to be, kind of remove the problem. And it was not about identifying the person that is the problem. Although some of this, what people are saying, it's this one, it's that one, it's this one. But it is a good case study and we have shared it. And there's two platforms where we shared it. The one is I have a once a month meeting now, which is called HOD Connect. And it's something that's a remnant from COVID. But we maintain this, and actually everybody still comes, like 180 people comes to HOD Connect. And it is an hour, sometimes an hour and 20 minutes, once a month on Teams. And we share 5 or 6 best practices or challenges. It's completely up to how people share. In that platform, we've shared so many different stories, and others learn from it, and others share stories and whatever. It's become really HOD Connect is something that everybody think, well, we want to tell our story at HOD Connect, or we want to hear from others in HOD Connect. So that's one. But the other one is also in the rural health services. Dr. Phillips have created this platform that the sub-districts that are similar are starting to work with one another, because Swellendam is similar to Swellendam Agulhas is similar to Beaufort West, because it's more than one sub-district. So she's also connected people across districts into networks of learning groups. So people are sharing now much more freely. And then the last thing is we have something that is called the ecosystem approach. The ecosystem approach, it is designed for somebody not feeling on their own where they're sitting, is we connect them to broader platforms. And people are very excited about the ecosystems because they learn from one another, and best practices are exchanged without us even knowing. People get together, share, and they do things together. So that is also how we address the issue of this complex surgeries. So the same ecosystem approach I'm talking about is where we are now saying, actually, complex surgeries is for the whole province. It's not Grootske and Tygerberg's problem. It's the whole system's problem. And actually, people are coming up with so many innovative ways, saying, but actually, if we just pool all our expertise, we can possibly get back to those complex surgeries, and we can do it in innovative ways. We don't have to wait for Grootske to build up this and then Tygerberg to build up. Figure out where we can do it. And we had a brilliant example at the HOD Connect, where complex surgery was actually done in Beaufort West. And that person was saying, the surgeon was saying how he cried when he spoke to the patient, because the patient then said 3 months later, she's a different person. And that person would have had to have had 2 assessments at Grootske, had to wait for the appointment, would have had to go there from Beaufort West, be assessed, come back home, then go for surgery 1, surgery 2, surgery 3. It would have taken her 9 months. This surgeon went to Beaufort West and he did it there. 3 months later, she was a different person. So there's all these things that comes out of this innovative way of ecosystems and thinking slightly differently about it. So we're very excited about the complex surgeries, because there's now a surgical ecosystem where people are trying to figure out innovative ways to come up with. So when you ask for the turnaround plan, the ecosystem is the turnaround plan, because everybody's excited. We want to do more things with what we have and think out of the box and do things. And in the same process, you also give people job satisfaction. They feel connected. They feel good that at Beaufort, we can also do surgeries like this and things like that. When it comes to executive oversight, we understand the need for any member to be able to do unannounced visits. But the only thing that you need to understand, we've had a situation where people arrive at our health facilities and they turn to us and say, somebody pitched up and say they're doing an unannounced visit. Who are these people? As health, our first responsibility, like I said with the statutory rape, is to protect the integrity of the patients that's in the facility. So people that walk into our facilities that starts asking questions, people don't know who they are, that starts taking photographs. You cannot take photographs of patients that's in our care, because you need to actually ask the permission of the person, or you start using names of people and you start throwing around. So the situation that we have is our staff are in a difficult situation. So for the one instance, somebody said she is a human rights monitor. So our facility manager, but now how do I know you're a human rights monitor? Anybody can walk off the street and say that you are a human rights monitor. So we have requested, as the management, some understanding and some appreciation for the difficulty that our staff finds themselves in when somebody arrives for unannounced visits. And all we're asking for is just some process of verification, some process of credibility, some process. We're not against unannounced visits, but the number of people that's come and the number of negative experiences people have had is that. And therefore, from the executive, we've approached the minister's office. We do need some guidelines because we are slightly different. I'm not sure what the rules are for schools acts and all of. We have a slightly different responsibility for the confidentiality of the people that's placed in our care. And there's very clear guidelines of when journalists comes, when people come, you cannot take photographs without the permission of people. You cannot go into clinical areas where somebody's sensitive. Even myself, when I do visits, I remember I knock on the door. I ask the patient's permission before I come into the door. If the patient doesn't give permission, nobody's going to go into the room. So it's those basic courtesies and protocol that we have to be mindful for ourselves. Then the measles death. I just want to check with Sam. Is there a registered death? Out of those cases, we haven't had a registered death. I normally if there's a death, and you would know if it's in that age group, you saw 5 to 9 is the biggest group. If there's a death, it will be in the death review. So there's no measles deaths that we have registered because it will register on our system and there will be a full investigation of the causes of the death. So Member Stevens, I did go to, I think I agree that we need to have a conversation. And we are, and I think it was about, the committee might be aware that in Delft something similar has happened and there's lots of complaints about Delft. My story is I was in Mitchells Plain Hospital 30 years ago and people were complaining about people sitting and, the doctors taking tea and taking their time. The triage system is one of those things. If you have an ill patient coming into a place like this, it can easily take you as a doctor at that facility an hour and a half to stabilize one patient. Easily. And that's while you're waiting for the ambulance, competing with other calls in terms of that. But the person in the waiting room's got no idea that that's what the doctor is actually doing. So there's two sides to the story always. I really welcome the situation because what we've introduced since my 30 years is the triage system. But then there's the unhappiness about the triage system that some people at some facilities are going to sit for 2 days. Everything is urgent for the person that's coming because they have a real pain. The assessment of the triage tool is they're not about to die, so we're not going to pay attention to you immediately. And everybody else that comes after you that's about to die, we're going to give preference to you. So we can understand the unhappiness and how it do it. So I agree with you that a conversation about that and the impact would be ideal. Thank you, Chairperson. Oh, sorry, there was one other. Sorry. Just one other was the severe malnutrition. So Member Windvogel, we shared that with you. 2 years ago, we with the DG Murray Trust did a survey in this province. It's called a stunting survey. One of the most heart-rending findings of our survey. And in the survey, we had to go to 2,000 households where there's a mother with a small baby and did the survey in home. Most heart-rending finding is 47% of those households ran out of food in the last week. It really hits you deep as a human being when you think, and where they run out of household, the last person to get the food is the child. So the parents themselves go hungry so that the children can have food. So because of that, we have launched something under Minister Wenger's, one of her priorities is something called Khulisa Care. And Khulisa Care is designed in Mitchells Plain, Khayelitsha, and in Breda Valley. That we're going to all the intake of pregnant women that are underweight and babies that are underweight at birth. And we're now going into enrolling them for support for the first 6 months of life. And we've worked in partnership with Checkers. The mother gets a 525 cash card with specific foods, it's like lentils, things that then can help that mother for the 6 months while the baby and the mother starts up in life, and we can connect them to DSD. We're very excited about the pilot. There's about 10 partners working with us. And we want to learn from those 3 sites, and from whatever the learnings is, we want to scale it everywhere because we believe this is a societal problem. Thank you.
Members, I'm looking forward to the discussion session, and I think we're going to really punch above our weight in that session. We're going to have tea, coffee, everything, and we'll go to town and back on that session. Dr. Klute, to you and your team, Mrs. Nkosi, Mrs. Brinkman, Susan, you and your team there from the ministry and the department. Thank you very much. And it's always a learning exercise to engage with yourselves. And then members, just before I let the professionals leave, I don't like going on a break and then coming back. Generally, can we release the officials? We finalize this and we join the youth leaders for tea and coffee. Mrs. Gosi will take them to the members lounge and then we'll meet them there. Are we happy with that? All right. Thank you, Dr. Klute. We'll have tea. We'll have tea and coffee with the HOD. All right. Thank you. Thank you, guys. Pleasure. Can we then go to point number 2 on the agenda, and that is consideration of our committee reports and documents? Can I shoot straight into the minutes, the approval of the minutes of the, it's not in month order. August comes before September. All right. Okay, I'm not going to be nitty picking. Can we start with the minutes of the 3rd of September? Member Van Minen?
Proposed minutes?
Minutes of the 3rd of September has been proposed. Any seconders? Member Stevens are seconding. Minutes of the 10th of September. Oh, sorry, it's a committee report. My apologies. Committee report. And then that was the 10th of September. We had a visit to Ceres. Member Van Vogel's highlight for this meeting of today. And I agree with her. She was very, very impressed. And it was my first time seeing Member Van Vogel, not having 20 questions. I was there. Member Van Minen was represented. Member, I know it was myself, alternate members and Member Van Vogel. Or can we come back to that one? Because I'm going to need Member Van Vogel for that one. Can we go to the committee report of the 13th of August? That was the Red Cross visit. Who was there? Member Van Minen?
Propose.
Member Van Minen is proposing the Red Cross committee report. Who else was there? Member Van Vogel, you were at Red Cross, the oversight visit at Red Cross. Do you remember? All right, Member Van Minen have proposed the report, the adoption of the report. Are you happy to second the Red Cross report? Just to come back on the Red Cross report, Member Van Vogel, because it will ring a bell. Yeah, it will ring a bell, and I remember even last time you raised the Red Cross issue. That will be dealt with when we get something in black and white. But can we accept that we've been to Red Cross? That is my gist. Okay. Yes, it is point 5, page number 5. page 5, number 5. So it will always be an outstanding issue up until, yeah. Thank you. It's seconded by Member Van Vogel. And then Member Van Vogel, I left this one for you. The Sears visit. Committee report of the 10th of September. And I did say in your absence, it was my first time seeing you not having 10 questions. And I attest to you, you know, what you said to Dr. Klute and his colleagues, that there's been a very visible turnaround at the Sears Hospital. So it was just the two of us, myself and you, who were there. The other members had alternate members who are not here today. So you propose, and I use my executive powers to support the committee report. And members, any other resolutions in terms of what we got out of the session? Member Waters?
Chair, just perhaps in a medical emergency, I think it would be useful for the department to consider some kind of a short what to do if you're confronted by a situation like that, any kind of emergency, who do you contact, how you should behave, some kind of as perhaps as a public education exercise. I think it would be useful. I'm not suggesting an expensive exercise or anything like that, but certainly we as public representatives have to sort of learn the hard way, and perhaps it's something we should take up. Otherwise, I think it was very clear.
I agree with that. It's part of any other business discussion. You've got that, Monday? Any other resolution that we might have missed? I think it's that. Yeah, there must be an engagement. Yeah. There must be an engagement on that. There must be an engagement on the triage. There must be an engagement on statutory rape.
Yeah.
Maybe we should not call it statutory rape. Maybe it sounds too harsh. The member van Manen had a term, yeah, teenage pregnancies. Yeah, a discussion on teenage pregnancies. Then the legalities will come out of the discussions. Sorry, which one is this? Oh, sorry, guys. All right, members, my apologies. I almost forgot about this one. And I think it was disseminated to the members. We received a complaint from a Dr. Isaacs. It is titled Alleged Irregular and Wasteful Expenditure from the Department of Health and Wellness. It was submitted by Dr. Samuels. Dr. Isaacs and Dr. De Vries, the couple of names mentioned. And I don't know if it rings a bell with you, members. The email was mailed about a week ago. Yeah. Now, yeah, it is about a complaint, and there are legal processes. It's a labor matter. He worked for the department, and there was a hearing at one stage, and they went to court. And I'm just giving you the gist of it. And he wrote to us to say that because of the ongoing engagement, he wants to have his job back, etc., and he's going to go to court. He's already preempting irregular and wasteful expenditure because he's paying legal fees. The department defends his complaints against them, etc. So in advance, he's claiming this. Now, in my understanding, this should go to, what is that committee? Public Accounts Committee. Yeah, so my suggestion is, because we've received it as a committee, we need to take a resolution that we refer that to that committee and they can deal with it, so that we are not seen as not engaging on what was sent to us. Member Van Vogel?
Oh, I support that proposal, Chair, that we refer to the council committee.
Okay, any seconder? I see Member Walters nodding. So Nomonde, have you got that? There is our resolution. Members? Oh, that's what we've done. Okay, thank you for that advice. Right, because it was addressed to all of us. But as a chair and myself and Nomonde, we will respond back to him to say that this is the action that we've taken. Thank you very much for that advice, Member Van Vogel. And on that note, members, the meeting is adjourned. Thank you very much.